So now we come to the fourth surgery, the duodenal switch or duodenal switch. And what you see in this picture is the reservoir of the sleeve. Does that look familiar? So that's where the sleeve came from, the duodenal switch. So the creation of a sleeve, and then a type of intestinal bypass, although much longer than the one I just showed you in gastric bypass. In this surgery, the bile limb is very long, the food limb and bile limb mix, and the so-called common channel is very close to the colon. So the design primarily of this surgery is really malabsorption, to get things to go through, okay? So this is our society statement again about duodenal switch. So weight loss is about 70% of excess body weight, with a mortality at that time published at about 1% or 1 in 100. So the advantages of duodenal switch is it is an excellent operation, and statistically the most superior statistical operation for people who have a body mass index over 55. It results in rapid weight loss, just like gastric bypass. It has superior weight loss durability. If you look at duodenal switch patients 10, 20 years out, they are really maintaining that high percentage of excess weight loss. It is very much a metabolic surgery, similar to the gastric bypass and the sleeve gastrectomy, and significant and superior resolution of other medical problems. The real disadvantage of the duodenal switch, and the reason why we don't use it very much and why it's used by less than 5% of surgeons in the US, is that there is increased surgical risk. The quality of life can be an issue because people can have very frequent bowel function, and it can be foul smelling and those sorts of things. So quality of life issues make the duodenal switch less advantageous. And there can be a higher incidence of, because of all that malabsorption, some significant vitamin and mineral deficiencies, especially protein and calcium. Okay, just want to now hit a few important things to highlight for you. This is a meta-analysis that was published in 2004 in the Journal of the American Medical Association that looked at 22,000 patients who had bariatric surgery in the US. The overall average excess weight loss, put all the surgeries and all the patients together, 61.2%. So this is the overall data. Diabetes completely resolved in 76% of patients. It resolved or improved in 86%. Lipid problems like high cholesterol and triglycerides improved in 70%. High blood pressure resolved in over 60%, resolved or improved in almost 80%, and sleep apnea resolved or improved in about 85% of patients. So those are incredible numbers. We thought at the time that this paper came out that there wouldn't be any way that insurance companies and people who are employing obese patients wouldn't jump on this and say, this is how we need to treat our obese patient population. And yet, here we are in 2010, and although things are much better and the data is more convincing, especially with regard to diabetes, we're still not all the way there. Here is a same paper, how these operations compared to each other. And this is improvement. So you see the percentage excess weight loss, mortality is pretty much as we discussed, and then these are the four, what we call big comorbidities: diabetes, lipid problems, high blood pressure, and sleep apnea. So you look at diabetes, improvement from a low of 76% in duodenal switch patients to a high of 93% in gastric bypass. The lipid problems, a low of 58% of the band patients up to 99% of the duodenal switch patients. High blood pressure, improved in 70% of the band patients up to a high of 87% in bypass. And sleep apnea, OSA, obstructive sleep apnea, improvement in 68% of gastric band patients up to 94.8% in gastric bypass. This is a paper that was done about 2 or 3 summers ago. It'll be 3 years actually, July. Came out in the New England Journal. A study from Utah where they looked at 8,000 gastric bypass patients and they compared them to 8,000 patients who were matched for their obesity that didn't have surgery. What they were able to show that in gastric bypass patients, mortality decreased by 40% in those that had surgery. And if you looked at specific causes, medical problems, for heart disease patients, mortality decreased by 56%. For diabetics, by 92%. And for cancer patients, by 60%. So this was a big deal, this paper. And this study's only been done in gastric bypass patient mortality benefit. I thought this is one of the better papers to show improvement in life expectancy. This Canadian bariatric surgeon named Dr. Christou, Nicholas Christou, they looked at 5-year death rate in their surgical group versus the same medically matched group at 5 years who didn't have surgery. These were gastric bypass patients. So in the surgery group, at 5 years after surgery, 0.68% there was a mortality of 0.68%, compared to the medical group of 6.1%. Okay, so they were able to reduce the risk by almost 90%. And there was a very similar paper done almost the same time, done by here at the University of Washington. So I want to give you an idea of what my surgical experience is. I've done 750 bariatric surgeries in my career through the end of last month. My gastric bypass experience, 526 surgeries, sleeve gastrectomy, 21, adjustable gastric banding, 138, revision surgeries, 65, and this is our mortality rate to date, knock on wood. And this is what I offer. I offer both types of adjustable gastric bands, both the lap band and the realized band. We offer the laparoscopic sleeve gastrectomy, the laparoscopic gastric bypass, as well as revision surgery. Okay?